Okay, you can start now.
I will greet patient and parent, introduce myself, Dr. Adnan, will take permission for examination. After wash my hand, then I will see the child, is he well looking or sick looking, then we'll assess his nutritional status in the form of height, weight, and head circumference. And we'll see in the surroundings for any saturation probe, mask, nasal prones, or oxygen cylinder, which I cannot appreciate in the picture. And I will look for any unusual features on the face and the obvious respiratory distress child is there or not. Then I will start.
Wait. Let her give the findings if anything is there.
Yeah,
Anything?
she's not speaking. Then I will
Yeah,
continue.
yeah, there is no respiratory distress, but there is cyanosis.
Okay. And then I will start my dependent examination from the neck for scars or any visible pulsation. Then move to chest as the child is already exposed. So then just I can see in the picture there is scar mark is there. Central sternotomy scar and lateral thoracotomy scar, which can appreciate. I would like to see further for the any obvious respiratory distress. Will count the respiratory rate and warm my hands. Put my both hands if the child is comfortable to check for the position of the apex and the character of the apex.
Okay, his apex beat is in the fifth intercostal space with the anterior axillary line.
Okay. Then I will start palpation on the left side. This one, yes.
Yes, left side.
Then I'll start my palpation. Uh, uh, at the apical area and the fourth left intercostal space, upper left sternal edge, and the right left sternal edge. I'm looking for any thrill is there or not.
He has, you are looking for murmur or you are looking for thrill?
Thrill, thrill.
No, he doesn't have thrill, but okay.
Okay. So then I will put my heel of the hands on the left sternal border to check for the any right ventricular heave or left parasternal heave, I mean to say.
No him.
Then then I would like to auscultate the heart in the all areas of the heart. In the apical area, the fourth intercostal space, left side on the pulmonary area and the aortic area, also the carotid area, and would like to know the character of the first and second heart sound, and also for any murmur.
Yeah, he has murmur on the left in second intercostal space. It is it's grade 3.
So I would like to check if the murmur is radiating to anywhere.
Where you want to see the murmur is radiating.
Radiating to the clavicles or the back anywhere, or any stern and on the sternum on the neck anywhere is radiating.
It's radiating to the back.
Okay, so that's great. Then uh, then I will try if the child is comfortable. I will would like to check on the back for any scar, any swellings, or any deformities there, and would like to auscultate in the back as well. As you told me, the murmur is radiating there, and we'll check for the basal crepitation as well. Is there any finding?
No lung findings.
Okay, so then if the child is comfortable, I would like to check for his hands. If the child is comfortable, would like to check for the uh, clubbing, cyanosis, and is there any pallor, stigmata of infective endocarditis in the form of oscillar nodes, genuine lesions,
He has
splinter? Yes.
he has cyanosis. You can see in the he has
Yeah,
still
cyanosis I can see in the picture also. He's clubbed or not?
there is mild clubbing.
Okay. So then I would like to check the pulse as well. would like to check on the both arms, would like to check the pulse rate, rhythm, character, volume. And this one especially, I would like to check in the brachial pulse is better because the child age is 7 months.
Mm.
So
Wait, you want to compare it?
yes,
You want to compare it?
yeah, I want to compare it also as well, and would like to check the rate, rhythm, volume, and character of the pulse.
Okay. Rate, rhythm is okay. Character is okay.
Okay, and there is no delay in the femoral side.
There is no delay.
Okay, then if the child is comfortable, would like to check in the eyes for the pallor and jaundice. In the mouth, I would like to check for any cyanosis and dental hygiene,
He
and
has,
would like to check for any palate deformity like high arch palate, anything.
he is mild pallor and he has some sinuses.
Okay, so I have finished my. I will check
Finish.
for the. Okay.
Hmm.
So I would like to, in order to complete my examination, we'll check the blood pressure of child and forelimb blood pressure and saturation in the room air. Would like to plot his height, weight, and head circumference on the growth chart, and would like to check which I could not, liver and the lower limb edema.
Mhm.
Okay, so today I have examined Joshua. He's 7 years old,
7 months.
and seven, sorry,
7 months.
7 month, 7 month old. I have started my examination as the child was only 7 months. So I have started my examination from the chest directly. So I can see there was his mid sternotomy scar and the lateral thoracotomy scar, and apex was in the fifth intercostal space, and there was no thrill, and there was first and second heart sound is normal, and there was ejection systolic murmur on the second intercostal space, and the child is mildly clubbed, and he's having cyanosis as well. So putting all together, my diagnosis is complex. This can be complex cyanotic congenital heart disease that has been first that has been first palliative surgery has been done, then uh, has been corrected, yes.
Yes. And what is the probable diagnosis?
Probable diagnosis, most probably tetralogy of Fallot.
Okay. And this palliative surgery has been done for what?
Yeah, that is most probably, which I can see there is a scar that is most probably was BT shunt. That is
Mm.
palliative surgery, and to take
Uh,
by time, and
to
then he was done for corrective surgery. As I can see, there is a scar, my mid sternotomy scar is there.
Okay, did you find any other scars other than these two scars?
I can see one scar, but I cannot see. This is not my, for me, picture is not clear.
Okay, these are
Let's see
drain
this one.
scars. Okay.
Drain scar, this one is I can appreciate, but this picture for me not clear. And there is some sticking also. I don't know what is this sticking white color.
And this is also the one of the drain scar covered
Yeah, drain
with the
scar.
plaster, covered with the
Yes.
plaster. Mm. Okay, so you said that palliative surgery was done for only just to buy the time.
Yes, palliative surgery or to, this is not actually a corrective surgery for the defect. This
Mm.
is by time and to just what we can say like
To decrease the pulmonary flow.
decrease this uh, flow to
Pulmonary
the,
flow.
pulmonary flow.
And also they want to grow the child for going
Yes.
for the corrective surgery. Okay, until you find, suppose the baby comes to you this neonatal period, and until you do the transfer the baby for cardiac center, what you will do before doing the palliative surgery?
Before doing the palliative surgery, if the child is newborn, so there is
Mm.
option of we can give prostaglandin to keep the duct open, because this defect is duct dependent.
Mhm.
Meanwhile, we will
So how you'll manage
we'll
at that time the child before you?
yeah, we first of all we will have to start the prostaglandin to keep the child open, this duct open,
Mhm.
so that then other things like if the child is cyanosed, though it will not affect, but we can still give the oxygenation and circulation as well. But that will be according to the child
Condition.
status. Yes.
Okay. And then after you then you after you manage and you send the child and you will counsel also the parents, right?
Yes. Yeah. Definitely, I will counsel the parent about the diagnosis and about the outlook of the diagnosis.
Okay. And regarding the this baby, you missed any other things in this baby?
Uh, I cannot appreciate any syndromic features because this child face is not straight to me, so I cannot appreciate. But I can see there is low set ears are there, which I can only appreciate, and depressed nasal bridge is there. Otherwise, thin lips, upper lips are thin, and I can see maybe this is smooth philtrum is there or not. I don't know.
Okay, no
In
problem.
the picture, it's not clear for me. But in the picture, I can see this scars and drain scars, and there is cyanosis. Sticking is there, and
Okay, no.
otherwise, in the eyes, I cannot comment. For me, this is depressed nasal bridge and high forehead and smooth philtrum can be there, and the upper lip is thin or what, low set ear.
Okay.
Otherwise, I cannot appreciate. Sorry.
No problem, it's okay. Just regarding your this clinical this steps, you missed a few things. You missed. I did not hear. Did you do this? Did you do the femoral pulse check with this?
Yes, yes. I told you in order to complete.
Okay, okay, okay. And the groins, you check the groin also for the any
Yeah.
scars.
Yes.
Okay. And what else you miss here in this, in the
So I approach I little bit change because he was 7 months. So I think for the 7 months should be start from the
I think the
chest.
one they told us in the also this exam that you start from hand, because that's why my my approach was I started from hand. Your approach was a bit different, so I was
No,
like
no, no,
rough.
no, no. My approach is also from the hand.
Uh-huh.
I always my template is also from the hand. But if the
Then,
child is less than 1 year, so
hmm.
better they are saying that should be started from the cardiovascular directly so that you can find some findings. Because if you will start from the hand, child may be a little bit disturbed and you will not find anything
So
after that.
then
You will not.
you suggest that if it is less than 1 year, you go from the cardiovascular direct instead of going from the hands.
Yeah, this one my teachers told me like this. If the child is small and he or she is in the mother's lap, start from there. Don't start from the hand. Start from the chest directly, so that
Mm.
you can find some findings. Otherwise, these childs may get irritated and they may start crying. So you will not find anything after that. So
Okay.
better to start from the cardiovascular so that you at least few things you can find. I don't know. So
So
that's
the
why.
question is finished. Your questions finished, Dr.
No,
Anna?
no, I have one more question
Yes,
regarding
you can ask.
regarding your this residual murmur. What do you think about this residual murmur?
Yeah, this one usually in tetralogy of Fallot, cyanose usually improved, but right ventricular outflow tract obstruction signs still can be present there. So this may be the residual murmur of pulmonary stenosis.
So you think that
This
still
can,
he has still stenosis on the right
yeah,
ventricular? protract.
Yeah,
So
this
how
can
you
be
will,
there.
so how you will proceed for this now? Then how you will
Manage.
further?
So for that, first of all, we will have to educate the parents and about the like all the diagnosis and the prognosis as well. So
Mhm.
this will be to keep in follow up with the cardiologist, and we will have to tell about some precautions like mm, uh, about the diet. Have to involve about the diet. So a child may need high caloric diet. So I would like to involve the dietitian, cardiologist, pediatrician definitely as well, and we'll learn the signs like if the child is having any time cyanosis, stop breathing, or not feeding well.
He is still,
So
so that
yeah, he's
happen.
still
You
cyanose.
need to convince the
So it
parents.
will take, yeah, cyanose. It will take time to improve
Mm.
as the corrective surgery has been done, but we will have to keep him in follow up.
Okay, so he will be follow up, and you will do the further investigations, right?
Yeah, that needs to be further investigation to check for if it has been corrected properly or not.
Mhm.
And for
But
that, we needs to do the echocardiography and ECG, and definitely after that chest X-ray. But
okay,
the mostly is echo is better to do. That will tell about the status of uh,
surgical
the
status.
ciliary. Yeah.
Okay, and what are the other causes of this median sternotomy scar?
So it depends upon if it is cyanotic or acyanotic.
Mm.
So median sternotomy scar is when the surgeries are done on the cardiac, on the heart. So if the child is acyanotic, so there may be a chances of some valvular lesions has been corrected.
You
Okay,
mean the
then
bypass? You mean on the
yeah,
pump?
if the child is acyanotic, if the child is pink and he's having mid sternotomy scar, that's mean maybe some cardiac surgery has been done, that most probably the any valvular lesions that has been corrected, or yeah, that
All
has been repaired, I mean.
all the
And if the child
characteristics.
is cyanotic, he's cyanotic, so that's means that some corrective surgery has been done, and
Mm.
that may be the some cyanotic congenital heart disease. So it,
Most of the
yeah,
corrective surgeries are done
yeah,
when it.
most of the corrective surgery in the cyanotic heart disease, yeah.
Okay,
And corrective surgery definitely in a cyanotic also.
okay, okay. I'm done with this. Okay. Okay, Dr. Noor, you can go ahead from the further questions.
No,
I'm done.
no, my question here is this child is operated and there is still residual pulmonary stenosis murmur and he's still cyanosed.
Hmm.
So you mean your question in management was to intervene this pulmonary stenosis again
Yes. Yeah.
by
No, no. My question was that how you will further manage for this one now.
yeah, that is what my understanding was. Your question was how do you intervene this pulmonary stenosis?
Yes, yes.
So it will be balloon valvuloplasty, right?
Yeah, we will for
So
that we will
later
have
he
to
said
see.
correctively. He said corrected. He said that he will do it, or he will do the echocardiography. You will do first echocardiography. You will see where you are.
First we will have to do the echocardiography to check
Hmm.
the gradient
Great. Yes.
gradient of the flow across the murmur. Then
Well,
we
well.
can consider further valvoplasty or balloon dilatation he needs or not. So that will be all in the tertiary care hospital, and definitely we will keep him follow up with the cardiac.
He
Yeah,
said correctly. He
they may
said
ask
correctly.
about the gradients in the exam. They have asked about the gradients. So if you know about the gradients, you
Yeah,
can.
gradient across the, if the gradient is more than 60, this flow is more than 60,
Above
then
60, above 60. Then you will
yeah,
go for the
yeah,
intervention.
For pulmonary stenosis also above 60.
Yes, pulmonary
yes,
pulmonary gradient above 60. If you have, then you will do any intervention.
yes, then you will give the intervention. You will do the
Because
intervention.
you know, in our cardiac center also they will follow. If there is something residual, they will follow the same as Dr. Adnan said, that they will give high calorie diet. They will follow with the clinical dietitian, the one who is following there. She will follow the child and do the echocardiography. If see the gradient is high, then they will do the intervention. If gradient is not high, they will keep him close follow up.
Okay. I don't know. I thought for pulmonary 40 and aortic 60. I don't know where I read this.
Because he's already done, the intervention is already done, because with some time, with time they improve. Sir, Dr.
Actually,
RAHMAN?
yeah, it's cyanose. Usually, cyanose is first improved, but you can see here, especially in this picture, this is not an too much old scar. This you can say like 15 days or
When you see, even it is fresh, and there is some still one scar is covered with bandage, so it is still
yes,
fresh.
So what
yeah,
is
this is
the
fresh scar,
impression
so
here?
it will take time to improve for the cyanosis.
Mm. So we have to follow up over time. But
Yes,
okay,
yes.
this is
Yeah,
a
yeah, yeah, yeah.
old operated case. Like I think in the exam it came as 12 years old boy with
Mhm.
the scars, and the presentation was he was going to play football and he has chest pain.
No, that is
Okay.
different. That is, this
Something
is
like
fresh.
this. In that way, they asked the management of now residual pulmonary murmur is there, and this child
Hmm.
has symptoms. So how do you manage? This was the question asked to the candidate.
So that one is completely different. He has
Different, different.
presented at 10 years of age, and now
Hmm.
he got the symptoms. So definitely this is increasing his gradient. Still, you will have to tell that we will first will do the echocardiography,
Echocardiography,
and
yes.
then we'll check the gradient of flow across the murmur, across the wall. After that, we will decide further what to do. This is so there can be valvoplasty or balloon dilatation. So better, I think so. We should not tell definite we will do this or that. We will refer to the cardiac
We will
doctor,
refer
and
to
he
the
will.
cardiac,
Yeah,
and
we
they
will
will do the
refer to
further.
cardiologist, but they can ask
Yeah,
what they do usually. They can ask. So we have to tell these two options only.
yeah. There are these two
Valvuloplasty
options are there.
or balloon
Balloon
dilatation
dilatation.
or valvuloplasty.
Valvoplasty,
So
valvoplasty.
from where you checked this more than 60, if you can tell me, I will go back and read it for the gradient, because
Actually, this one I have studied maybe 3 years back when
No,
I was
because
doing my.
I am working in cardiac also now, so they are always talking about this more than 60.
Maybe I have.
Dr. Rehana, I think it's for aortic. For pulmonary also, I am not sure. Pulmonary is 40. But go back and check. Let us check from the
Okay, I
report.
will
Let
ask.
me
You are
I will
right.
confirm.
also.
You are right.
Let me
Yes,
confirm. Let me confirm.
Pulmonary valve
yeah,
is 40. For aortic valve, it is 60. And
Maybe I'm wrong.
one
Yeah,
minute, 1 minute. And I also want to tell you that
Mm.
during the meeting I was doing recently, meeting on cardiac, someone said around the valve is 40, but the pressure in the right ventricle,
60. It should be 60.
I will
it
just
should
give
be
you
more than 60.
confirmation. Just give me 1 minute. I'll give you confirmation.
Okay, no problem.
Across
But
the wall is
whatever,
40, and in the right ventricle it's 60, as Dr. Noor said. It's
yeah,
right.
this is what I got from the meeting. Someone said, but I wanted to check. I did not check back, but I remembered.
Pulmonary is 40.
Yeah, yeah.
Pulmonary across the valve. There are two things here. One is across the valve and in the ventricle. Across the valve, gradient should be more than 40, and in the pulmonary, in the right ventricle, the pressure should be more than 60.
It's written then as same in Nelson also.
No, not
No,
Nelson.
Nelson.
Delta
No,
U.
no,
They're
just
not
to.
following Nelson. They're not following Nelson. Wait, I will give you the
So
confirmation.
that's why I am telling you, let's not go for our local also or anywhere also. Let's go back and check this from the UK, or I will ask in the group if anyone has, they will send me fast, no problem. Because this was told to me in my general meetings when I asked this question, and they told me, because this question was asked to the candidates in the exam, please know about the gradients across the valve. I know the questions what they ask, but I don't have time to see. This is the biggest problem. From morning, I am struggling to read TOF, but I did not read. But I just went through the cyanotic neonate because I want to give the case. Like this is happening with us because
Even in Mrcpch, I'm now checking. Mrcpch has not written.
No,
These
it's not written. I read Mrcpch whole
not
CVS. I
written
didn't
in
find it.
Mrcpch. It's
It's
in
not
figure
written there.
notes.
I read it. I read it for.
It is in figure notes, but we have to reconfirm it Okay.
I'm confirming. I will give you the confirmation. Don't worry.
Okay, no problem. So till then, just be about aortic stenosis and pulmonary stenosis. We should know the gradient when we will intervene. This question is being asked in the exam. Okay.
Actually, I'm not also sure because I have studied this when I was doing my PG. So I have studied that time. This is maybe 3-4 years back. So that's why I also kept
Dr.
quiet.
Yasir, did you read from anywhere?
Nelson, as in the it was discussed in meet. I will check from the other sources, but I confirm from Nelson.
Okay. Dr. Rehana, tell about your case, from where you took the case and made this case.
This
Dr.
was
Ruhail, I have some issues. First of all, First of all, what do you think? What procedure they have done for this scar?
There are 2 scars are there.
No, that's not me.
Sternotomy scar, actually for the corrective surgery, they are doing this repair of the VSD and this pulmonary they are doing for that also. But
they are doing the spot
Do you think this is now after surgery? Now after surgery, your diagnosis is stopped. But my question is this one: do you think after surgery, still there is some, because the surgery is to dilate the valve, because in most of the case the valve is atretic, they are doing this surgery, and there are we can get. So what do you think? Still residual is left?
no, this is actually the fresh scar is there. So that's why I was thinking, maybe, yeah, this is a fresh scar. But usually what they are doing for the corrective surgery, they first repair the VSD. I think
they put
that
a patch, they close the VSD, and they
close the
do a
VSD
surgery and make a open conduit of the pulmonary
yes,
wall.
they are doing this augmented this
transannular patch.
pulmonary wall.
Transannular patch. They do transannular
Yes.
patch.
Yeah.
So
But my
this can be
question is still there.
possibility.
Why he still having cyanosis?
No, this is fresh. It will take time.
Well,
Fresh.
as
Yeah,
I
he's
have
right.
seen the patients, as they did surgery, just after the surgery, they are yellow. Sorry, they are red. Full
That
blown.
pink. You mean
Only
pink?
only clubbing is left that we can identify. Otherwise, we cannot identify before going to operation theater and after coming the operation theater. There's hell of difference.
So
For me
possibility
also,
they have not corrected this one. They had done only VSD, correct?
The other possibility, maybe they did just only BT shunt.
No, but there is
No, BT shunt they cannot do from the mid sternotomy scar.
Yeah,
that
BT
is from
shunt
the
they will
lateral thoracotomy.
Okay, I will check again, because I have seen a patient, they perform the surgery, and because they're saying anatomy we have changed, we close the repair the obstruction, and now he become acyanotic. And we have seen a lot of patients, because in children hospital, we also work in cardiac surgery wards and cardiac surgery ICU.
But
So
this is boss. This is not possible that they have done palliative surgery for with the mid sternotomy scar.
I will check. But you
America,
mentioned in your description that before he had any palliative surgery, have you observed any scar?
Yeah, there is
another scar. If you will check on the picture, there is another scar.
There is left thoracotomy scar also, Dr. Yasin.
Wallah.
Check there. That's why
clear in the picture. It's not clear in the picture, but Dr. Rehana gave him the finding. Sometimes if it is not clear in the picture, it will. That's why there are two things here: universal Q and dependent Q. If it is not clear in the picture, you can ask the examiner and he will tell you. More than that, what Dr. Yasser said, I agree with him. Once there is corrective surgery done, clubbing is there, it's okay. But cyanosis, that means there is some problem in the corrective surgery. It's not done properly, or there is some failure or anything.
This one which I am seeing, or maybe I can wrong, but this one is the scar is there.
But the lateral,
there is scar.
Okay, but the lateral thoracotomy will not come like this. It will come like this.
Yeah, this is coming like this. I know this one coming like this.
Half moon, just like this one.
The lateral thoracotomy will come like this.
Yeah.
like this it will come.
Yeah, I know, but this
Yes, like the blue one. Who marked the blue one? Like that it will be.
Me. Okay, so it's okay. Forget it. We just want to know the case. Okay, tell about your case, Dr. Rehana, from
this
where you took and
This is from the previous examination case, from the exam, mock exam. And
okay, tell
I
me.
prepared from the mark. I did not read other books. I did not have time to read other.
No
no
problem.
mark is more than enough. Mark is more than enough.
Yeah,
Yeah.
mark I did only from the mark.
Okay, no problem. Just tell me, like,
This
he
this
gave
car
only
is there,
one
Doctor.
differential. Listen to me. He gave me only one differential, but we cannot give like this one differential in the exam. At least
They
three
should give
differentials.
three at least. They should give three at least.
Yeah. Tell the other differentials.
What are the other differentials, Dr. Adnan?
So here we can keep the differential with the pulmonary stenosis with VST.
Mm.
Okay, pulmonary atresia with VST, so- and complex cyanotic congenital heart disease, and tetralogy of Fallot.
First will be tetralogy of Fallot because the common is tetralogy of Fallot.
First will be the tetralogy of Fallot.
It can be TGA, but it cannot be because he's big.
Yeah,
No, it can be TGA with pulmonary stenosis.
pulmonary
Yes.
stenosis. Yes, TGA
Yeah,
with
Yeah,
pulmonary
all
stenosis.
the cyanotic heart disease with pulmonary stenosis.
Can be, yeah.
Uh, pulmonary stenosis with VSD, complex cyanotic heart disease with the tetralogy of Fallot.
Yes.
All these will be my differential.
But
Yes.
patient with VST and pulmonary stenosis should be cyanotic.
Critical pulmonary stenosis with
Critical
VSD
pulmonary
will be
stenosis.
cyanosis.
Sinus. Critical pulmonary.
Yes.
Because if VSD is there, he will not have cyanosis. There will be mixing already.
Okay, no problem. And Dr.
Okay,
Ruhel, there is no mild clubbing. Clubbing is present or
No,
not?
this one I did not said. Mild clubbing has been told by
I said
examiner.
this. You did not say that. The one.
Yeah,
I read it from
one told-
somewhere.
Yeah. This one told by Dr. Rehana by
Okay,
examiner, and
Will it
there
look
can
like
be
this?
grade 1 clubbing can be there, so that will be mild. I
Okay,
think so.
no problem. And regarding the management, we
There
will
is,
say-
Dr. Yasir, there is. I read it one book, clubbing. They wrote it mild, moderate, severe. When there is no, when there is no shape at all, diamond shape between the nails, that means he closed his severe.
clubbing
Actually,
has
they
4
are saying
stages
that
only.
if there is
Clubbing has only 4
no
stages.
sham
Mild,
outside.
moderate is not criteria.
No,
Clubbing
they
has
are
4
saying that
stages, you
if
know.
there is
Tell me the stages
There-
of clubbing.
Loss of
Dr.
angle.
Yasser, I will tell you, they in the exam they are not bothering these things.
Yes.
I will tell you this
Okay,
time
okay.
the exam, Dr. Aftab got this cystic fibrosis. Okay,
Mm.
cystic fibrosis, and there was thoracotomy scar, there was another scar, and there was this lobectomy scar. Sorry, so but the child was not clubbed.
Yeah, I am asking, I discussed that one. That could be a case of cystic malformation, congenital cystic malformation.
I was thinking the cystic malformation, but the child age was 10 years.
No problem. Because the patient is in UK, not in
and-
Pakistan and India.
And even I will tell you, even I will tell you, the examiner by himself said that, yes, this is cystic fibrosis. Then what will you say?
Khalas, it's a pneumatocyl.
No, he said-
Obstruction can causing that one, recurrent infection, pneumonia.
If
That
this
can
is
lead
cystic
to this
fibrosis,
one.
why? No. If this is cystic fibrosis, why there is no clubbing?
No,
He
Dr.
said this
Here,
is case of
clubbing
cystic
come
fibrosis.
when clubbing come only for 2 reasons in cystic fibrosis. One is hypoxia and second is fat malabsorption. If both
Only by cardiac. Gradient only by cardiac care.
Okay,
Yeah,
so-
gradient will be catheterized.
So here the differential diagnosis was we will always present the case like this to start with. In the end, this is a case of complex cyanotic congenital heart lesion which is already operated and maybe has had a shunt procedure before. That means or you can say shunt or a palliative procedure before.
Yes.
And you will give your differential diagnosis. Most probably
Better they said to say palliative. One of the, this said shunt, They said you don't know what they did a palliative. Say palliative surgery.
Okay, with most probably palliative procedure. So use these words. This is a case of complex cyanotic. Since there is cyanosis, you can say cyanotic in this child. If there was no cyanosis,
We'll say complex congenital heart
complex,
disease.
It's complex congenital heart disease.
Oh, that's it. If you are not sure about cyanosis, confused, that is a cyanotic, just tell a case of complex congenital heart disease has had post-operated and maybe had a palliative procedure as well, because the lateral thoracotomy is for that, right? Most
Yes.
probably due to, you will give your differential diagnosis. Here you said tetralogy of Fallot. Other things, what you, pulmonary atresia.
Pulmonary atresia.
Yeah, pulmonary atresia with VSD, but yes, that can be, or critical
With or
pulmonary
without
stenosis with
VSD?
VSD. Yes, and TGA with
Pulmonary stenosis.
pulmonary stenosis.
So we can
RAHMAN, critical, we cannot say also critical pulmonary stenosis because that's also one of the.
I think here the differential diagnosis, we can give all the differential diagnosis of right-sided heart lesions, which will cause congenital cyanotic disease in the newborn.
Yes.
Like what, all right-sided lesions like pulmonary atresia, tricuspid atresia, critical pulmonary stenosis. Okay.
Yes, critical pulmonary stenosis.
And severe TOF. Usually severe TOF will come in early age, but this is 7 months. We can just say TOF, no problem, but he has already been operated and everything done, means maybe he would have
This is the age for TOF, not to get for the corrective surgery. 4 to 6 months they usually do the corrective surgery.
so but usually severe TOF will present.
They will come early. They will come early.
They will come early. That's why always all the differentials we can give for the right-sided heart lesions in this. This is what I'm telling.
Yes.
Like pulmonary atresia, tricuspid atresia, critical pulmonary stenosis, and TOF. I think this much is more than enough.
Actually, Dr. Noor, we can say TOF. We can say double outer right ventricle with PS. We can say TGA with PS. So we can keep these three differential. I'll know this. Other can also present, but with this scar mark and with this one, it will help us going
Like,
more towards.
No. What about this for critical pulmonary stenosis? We will not do the palliative procedure of this.
Yeah. So that's the reason these are TGA with PS, with double outlet right ventricular, with PS, and with the TOF with the PS. In all these of them, we are doing the surgery. So with this scar mark, we can keep them in priority and others on the down the list.
Means suppose the lesion is just critical pulmonary stenosis, then they will try balloon valvuloplasty.
Yeah. By catheterization.
Okay, there should be some complex problems like double ventricular right
outlet right ventricle.
Right ventricle. Okay.
And other thing I want to clear, is there any role of a prostaglandin in TOF in neonatal time?
Yes, there is. In severe TOF, severe TOF will be a duct dependent lesion. Yes, there is.
They will depend on if any duct dependent, then you will need to start.
Okay, after the second case, we can just a similar case of Dr. Rehana is there in Mark. Only that we will go through later, no problem. Now, what is our second case? I forgot.
This is usual thing. This is usual thing we forget.
Okay, you can start, Dr. Yasser.
Yeah.
The findings.
1 day old baby lying comfortably in the lap of the mother, having a nasogastric tube inside with the IV cannula on the right forearm. And he's having a saturation of 49%, heart rate of 157 per minute. He is clinically, he looks cyanosed and with no obvious respiratory distress, having a dusky look.
There is
Uh,
RR in the picture, you can tell RR. There is RR in the picture, if you can find out.
Yeah, sorry. R is 49 per
Okay.
minute, and
Okay.
saturation is 53 percentage
Okay.
at room air. Uh, mm, mm,
So this is a cyanose neonate. So what history you want to take?
I want to see onset, for how long he has, for duration, and it progressively increasing. Any aggravating or any relieving factor, any dysmorphism, any other abnormalities, uh, any history of antenatal history from the mother, any infection, um, uh, uh, any
Okay.
fever, any rash,
Okay.
and any other history, family history of such disease in the family.
Okay.
Um,
What else you want to take? A history. Okay, no problem. You can proceed with
any
what?
drug history of medication drug mother is using.
Okay, just now the baby is born and prenatal history you did. Okay, what examination you want to do?
I want to do his um, uh, this cardiac examination. I will start from general physical examination. First of all, I want to do the cardiac examination. I will have to see the chest to see
What you
any.
want in the chest? What you want to look for
I will
the?
see for symmetry, deformity, any visible pulsation. Then I will palpate the apex beat and see the character. And then
Okay, okay. So CVS examination you do. What else? What other system you want to examine in this child?
I want to see the abdomen for hepatomegaly,
Okay.
and other I want to see his periphery. I want to see his periphery.
Okay.
Either they are cold, or to see the sign of poor peripheral perfusion. I want to see cyanosis. I want to see this radio radial and radio femoral delay. I want to see the pulse rate, rhythm, character, volume, and I want to do
Okay.
see the lower limb edema and back also.
Okay. So anything else you want to do, or you, if not, go to differential diagnosis.
I will for differential could be a case of is a case of cyanotic congenital look like cyanotic congenital heart disease, which could be possibility of a tetralogy of Fallot, transposition of great arteries with the pulmonary stenosis, and could be a case of double outer right ventricle, and could be a case of critical coarctation of aorta.
Okay. So critical coarctation of aorta will present with we will present with cyanosis more commonly, or with pallor and shock.
Yeah, that's the reason I put it at the down. They are
Okay.
presented with
Okay.
shock, but I put at the
So
fourth number.
TOF, TGA, and double outlet right ventricle. Anything else? Okay, give the other differentials.
It
For
could
this
be a case
case.
of truncus arteriosus with the pulmonary stenosis.
Okay, this leaving congenital heart diseases. Other differentials, please.
Could be a case of supraventricular tachycardia.
Okay,
Could be a case of
157 is the heart rate for you. Okay. Uh, okay, other differentials. If not, you can go for the investigations. What investigations you want to do in this child?
I want to do chest X-ray. I want to do echocardiography, cardiac catheterization, electrocardiogram.
Okay, you will go directly for cardiac catheterization.
No, first of all, I want to do chest X-ray, ECG, echocardiography, and then if there is abnormality, then I will involve the cardiologist and then I will proceed with cardiac catheterization.
Okay, suppose now you, because the child is cyanosed and the SpO2 is 50, now the SpO2 is 53. So you gave oxygen to the child and the child is not improving. Okay, the child is not improving with your oxygenation. So what do you suspect in this child?
That he has a cardiac pathology, not the pulmonary pathology.
Okay, so how do you want, if he has cardiac pathology, what is the initial management you will do in this child? Before
6 minutes.
the cardiac center.
Continue.
6 minutes
Okay.
finish?
Yes.
Okay, no problem. Let's just continue. Okay, tell the management plan only is left now. How will you will manage?
I will do a multidisciplinary team, involve a multidisciplinary team, which having cardiologist as a key role. I will involve a pediatrician for his for the management of his diet.
Now the child, okay. Now the child is cyanosed and you are there, and and his SpO2 is 53 and his oxygen is not improving. So what is the first step you will do for this child?
Because as already you told me, we provided him oxygen and he does not, there is no improvement in the oxygen saturation. So most likely this child has some cyanotic heart disease that doesn't need any oxygen at the moment. So, but I will involve the pediatrician that keep an eye to avoid and prevent the cyanotic spell. I want to keep him good diet, involve dietitian to keep him good high calorie diet.
Tell me
Then
about the emergency management. What plan you will do for this child? What is the emergency needed here?
yeah, there are chances of TET spell in such children. So we guide the parents to avoid any dehydration, any
Okay, but this is just one day
stress. We
old.
provide them oxygen. We provide them high flow oxygen. We give him morphine. We put a squatting position,
No,
and we give propranolol, this beta blockers. And then if there is any acidosis, we can correct with the sodium bicarbonate.
Okay, I want to tell you that this child is still not confirmed as TOF and he has no cyanotic spell. This is the initial presentation with cyanosis not improving with oxygen. So what is the most important medication to be considered here?
Prostaglandins.
Yeah. So prostaglandins. So how do you give prostaglandins usually? Who
We
will involve the team here?
we will involve a cardiologist. We will involve the intensivist, and we will involve pediatrician.
Okay, intensivist. So can you tell me the side effects of prostaglandin? How do
They
you
can
monitor the
affect
side effects?
we have to monitor the urine output, and they are damaging this one, the kidney. So we have to monitor the renal function test, and other I will check. Sorry, I
Can you
forgot.
tell me the common side effects? Most common. Okay, no problem. So most common side effects. This is the common question which is asked: side effects of prostaglandins and how do you manage?
Okay, I will check.
Common side effects of prostaglandin. This is the main thing here. The management main is always when the management is asked in this child, even though we have already told you that oxygen is given to the child. Still, when we start with the management, we will start as AB. We will check the ABC of the child. And in this child, we already know that given oxygen and not improving. So ABC of the child, vital signs, and since this child is not improving with oxygen and his RR is just 49, it is not like 60, 80, right?
Yes,
So
yes.
maybe the respiratory cause is less likely here. His RR is just 49, it's not above 60. So the respiratory cause is less likely here. So you will tell that I will check the ABCs. That is, let's not use ABC. We will say clearly, I will check his airway, breathing, circulation, then check his vital signs. And since I know that his oxygen is not he is not improving with oxygen, most likely this child has cyanotic congenital heart disease. So I will involve my consultant, and you will involve the team simultaneously, consultant, cardiologist, and the neonatal intensive care team will be involved. And we will consider for an urgent echo. If it is available, an urgent echo will be done, and we will consider for cardiology for prostaglandin. So under the neonatal ICU team care. So because this child needs monitoring when we give prostaglandin. So what is the monitoring needed when you give prostaglandin? Any idea?
They may have apneas.
Yeah, so ventilation. So you will be ready if they may need intubation also. So whenever prostaglandin is going on, it will be in the NICU, and all the intubation set will be ready, and the neonatal team will be continuously monitoring the child if needed to intubate or ventilate or bag mask, whatever. This is the main thing you will tell. Like this you will start. Okay, always start with ABC, even though it's given before, even though it is done before. When management is set, we will say, I will check his airway, breathing, circulation. I will check again his vital signs. And since they have already given you the finding, and also his RR is not fast, this is mostly, they may ask you a question. Suppose there is no facility in your center to do echo. Okay, so you will shift the baby without giving prostaglandin.
Yes.
What do you say, Dr. Adnan?
What is the question? Sorry. If
Uh,
I'm
the
Echo
question,
facility is not available in the primary care, so still we can start prostaglandin infusion.
no, not facility. You have NICU and everything, but you don't have a facility to do echo. Suppose you did not do the echo, and the child is presenting like this, not improving with oxygen.
yeah, then we'll have to give because this is life saving.
No, you will
Yeah.
start. You will
You
start.
will start the prostaglandin. You will stabilize the
Yes.
child. Then only you will shift.
Yeah, that it is because this is life saving, because he's having cyanotic congenital heart disease. Anytime he can deteriorate, so we can start prostaglandin.
Yes.
No problem.
Yes. So this is the answer. I thought that I told you did not read this from the from where you read, Doctor.
Diagnosis.
Yeah, cyanosis will not be there. Cyanosis will not be there.
Yeah,
Definitely.
otherwise look is the same.
Differentials now. Let me give you the differentials now. For this child, okay, the again, this is here, the child is alert. See, you can tell coarctation of aorta only, like initially it will not present with cyanosis. Maybe
Yes.
a long time standing, then it will present with cyanosis.
Actually, sorry, there is a scenario, dusky color, and but with respiratory distress and sign of peripheral perfusion, means shock, cardiogenic shock they are presented, or pneumonia like they present. But I put it and the
No problem. But I'm telling you, in this infant, in the exam, what we have to do, what is the most commonest for this? Better to give that and keep the rest in the down. I agree with you.
Yes.
But here you should not, for a this is cyanotic neonate. They haven't told you whether it is cardiac or respiratory. In any cyanosis, two systems play an important role, that is cardiac and respiratory. Okay.
Yeah.
So here your differential will come first is cyanotic congenital heart disease. This because it is not improving with oxygen.
Yes.
Okay. Give me another condition which may not improve with oxygen. Apart from cyanotic congenital heart disease, all the diseases came of the heart. Apart from that,
AV malformation.
what about PPHN?
PPHN, pulmonary persistent pulmonary.
Your second most nearest diagnosis to this is PPHN.
Okay.
Mm-hmm.
Yeah,
Second most nearest you will give is the PPHN. Then the third one always in neonate sepsis.
Yes, sepsis. Yeah.
Third-
It's a
third
1 day old.
Why I am
One-
not going for respiratory as the third one is because the RR is not supporting me. And not improvement with oxygen is not supporting me. So third, I will put sepsis. Fourth, I will put respiratory. This is your broad differential for this case. Okay.
Yeah.
What
You
is
are
the broad differential for cyanotic neonate? Just don't go on listing the congenital heart diseases. First is the cyanotic congenital heart disease. And also I want to rule out persistent pulmonary hypertension in this child. The third thing is I want to rule out sepsis and I want to rule out respiratory. So what you will do first, when this picture is shown, I will go step by step for you, but I may be wrong also. I am trying my level best. So when this picture is shown to you, what you will do is in your paper, okay. So in your paper, you will first write the DDs.
differential. Yeah.
The 3 minutes time is there for you, right? Or maybe the video, I don't know how it goes. I don't know. At least we will put differentials in our mind. What is my first? What is my second? What is my third? And what is my fourth? Based on that, I will ask history. Based on that, I will do examination. And based on that, I will give DDs and investigation and management. Okay. Like this, we have to plan ourselves in any station for that matter. So let me go back here. So in this station, I wrote this much of differentials now. After cyanotic congenital heart disease, PPHN, then sepsis, then RS. This is my 4 broad differentials. So based on that, for the cyanotic congenital heart disease, what history you will ask here? Now this baby is just one day old. You don't have much of the past history in the baby. It is born and it is presenting to you with cyanosis. Okay. So so for to know that whether the child had congenital heart disease from before, what history you will ask here? Anyone?
only antenatal we can ask.
Yeah, antenatal, what history you want to take? Antenatal, what history can tell you that maybe the child had some heart disease inside the womb? What history will tell you?
Infection, just like rubella or something, torch infection.
More than that.
Any
You
drug.
asked for infection already. Infection will give you for sepsis.
Sepsis, and I am also thinking for rubella.
Okay,
And
rubella will cause what heart lesion?
PS, pulmonary stenosis, and VSD.
Okay, fine. The important history you have to ask is antenatal scans. Any antenatal scans are done and any congenital heart disease was recognized at the time. But here it is not history station. The role player will not ask you. You will just tell what history you will ask, right? You're just telling. So antenatal scans is very important here. You will ask about antenatal scans. Then for the cardiac, and also you can ask other things like what? Maternal age, like Down syndrome. The most common is the Down syndrome, right? Presenting with the congenital heart disease. So maternal age will also help here. Then what is my next diagnosis? PPHN, I cannot ask much. Even the antenatal scans, if they have discussed anything, it's okay, leave about this. The rest is the sepsis. For the sepsis, you will ask what? Fever. You already told fever with rash in the mother, prolonged labor, premature rupture of membranes, all these things, right? Any GBS positive, all these things, right? Any tests done for the mother, anything given for the mother. Okay. And also in congenital, you can also ask about the preterm. This baby is looking term, but still you will ask whether the baby born preterm or has any, because PDA preterm. Okay. Like this. After sepsis, our last thing is the respiratory. So related to respiratory, what questions you can ask? Like during the means after birth, like passage of any passage of meconium inside the womb, and for preterm history will support you for respiratory distress syndrome, and the infection history will support you for pneumonia. These are the 3 respiratory. What 3 common differentials you can give here is the congenital pneumonia, respiratory distress syndrome, meconium aspiration syndrome. Okay. So all the your history will be based on your differential diagnosis. Okay. So always if you write the differential diagnosis, it will come in your mind what I should ask in the history. I agree with you. Infection will cover up everything. It will cover sepsis for you, can be some congenital heart disease related to it, and can be some respiratory like congenital pneumonia. But what about the antenatal scan like Down syndrome or any investigations done during any prenatal investigations done during pregnancy? Like sometimes if Downs is there, they can do prenatal examination, right? So antenatal scans and prenatal examination, maternal age, and sometimes even oligohydramnias is very important. Why oligohydramnias? I can connect this to respiratory oligohydramnias. Anyone? Because of this Potter syndrome.
Potter.
Yeah, but less likely. Still, I am telling you, I don't know what kind of case you will give. So what picture universal Q you see, after seeing the universal Q, put the commonest diagnosis in your mind. What can come here like this? What can come in this child? Which should be my top? Okay, you don't know now, but by RR is giving you some clue in the in this. This may be most probably cardiac, may not be respiratory, because RR is just 49. This is a clue for you, but still the examiner may give you some clues also. Then after examination, you just told me cardiac examination and hepatomegaly. What else important examination you missed in this child? Two important examinations you missed in this child. Others can also tell. He told cardiac, and he told hepatomegaly, and he told lower limb edema. This all belongs to cardiac examination. What else he left?
Respiratory examination could be there.
Yeah, respiratory examination, even though, because it is our differential. Again, all our examination is based on differential respiratory. Then what else? For the sepsis, maybe the hypotonic, baby is hypotonic.
Yes.
For the sepsis, hypotonic and poor feeding, whatever.
Yeah.
So in the examination, always start again that I want to check the complete vital signs of the baby and do the complete cardiovascular examination, respiratory examination, and also check whether the baby is hypotonic, poor feeding, going with features of sepsis. So I will do complete head to toe examination. Okay, small babies, you have to do everything, but at least mention about hypotonia in these children, hypotonia, refusal of feeding, whatever. Okay, this is the examination part which was missed. RS and whether some examination for sepsis. Then in the investigations, you told me ECG, echo, chest x-ray. And what else you told? Chest x-ray, ECG and echo, and cardiac catheterization. What about your, based on your differential, sepsis is your
Blood culture for
sepsis is your differential. So you have to do,
SBC and blood culture.
yeah, so you will tell, I will send the septic workup, complete septic workup for the
Complete
child.
septic
Complete
workup.
septic workup for the child. But you, for LP and all, you will stabilize the child, which we all of us know. To start with, at least we will send CBC, CRP, blood culture when we extract the culture, and also urine. Then for the LP and all, you have to stabilize the child. The child is cyanotic, you don't know, but you have to tell about the septic workup. Then okay, anyways, for RS already covered, chest x-ray you did, it will cover for you if there is any pneumonia or anything will be shown there. So ECG, echo you covered for the cardiac. Okay, so your differentials is covered now. Then so your investigations is based on this. Then again, I told you always management start with, I will check the baby's airway, breathing, circulation. I will again check complete vital signs. Then I will go. Then the examiner may give you, if this is a congenital heart, cyanotic congenital heart disease, what is your management plan at the moment? So immediately I will involve my consultant, my, what, as you said, you told all these things, cardiologist, and a NICU team or intensivist, whatever you want to tell, you can tell. These three people comes into role here. And because I want to consider prostaglandin in this child, you will tell like this: I will involve these three because I want to consider prostaglandin in this child as a life-saving medication. So then they will start asking you about prostaglandin. What are its side effects? Okay. And also they may ask which prostaglandin is commonly used. It is mentioned in the red book. Nowadays they are using E2 more commonly. If E2 is not available, they will go for E1. Just remember 2 is more commonly used. No need for doses and all. They will not ask you. If I will consider prostaglandin, and suppose you don't have echo and you want to transfer the child to, do you transfer? Like this, they will ask you tricky questions to see that how you will emergency management, even if you are not supported by anyone. At that time, you will tell, you did this, give this oxygen and he's not improving. His RR is not that high. You are suspecting cyanotic congenital heart disease. Maybe you auscultated, there is murmur for this child. All these features is going with, by your clinical examination, going with cyanotic congenital heart disease. So what you will do, you will tell that I will consider prostaglandins with after involvement of my consultant, stabilize the baby before transferring. Okay. And their favorite question is, even this question is there. You can go back and check one more mock video in the RCPCH website. Their favorite question is the side effects of prostaglandins. Okay, I will ask now. Dr. Adnan gave me very good side effect, apnea. Any other side effects?
Hyperthermia.
Yes. Okay.
And the hypotension, seizure-like activities can be there.
Yes.
Cardia, tachycardia, vasodilation.
Yeah, you're in cardiac center. You'll tell me. Okay.
I sent you also the guidelines for the pulmonary stenosis in the group. Huh?
Okay. This is from, if it is from UK, then only I will consider. If it is from any other.
Overall, international guidelines. It's not only UK.
Okay. Okay. See,
I read it somewhere in RCP. So that's why I remember 60. I read in somewhere. I don't remember the book.
Okay, now you told very good. You told hyperthermia, you told hypotension. What else you told?
Bradycardia, tachycardia, vasodilation, as it is a vasodilator.
Yes, you're right. So I will give you one clue to remember, but this is from one of my friends. This is not from me. Don't think that this is from one of my good
Okay, supply, pass the knowledge. It's good. Sadaka.
And because it is in this recording, I don't want to take anyone's names. We'll just.
No, it's okay. Just pass. She will get benefit for the rewards from Allah, inshallah.
So it is normally keep vital signs in your mind. Okay. Yes. So normally what vital signs we check? Temperature, pulse,
blood pressure, pulse,
blood pressure, saturation, RR. Okay.
So temperature, it will be hyperthermia. So very good.
Temperature, hyperthermia. That is why we use paracetamol, NSAIDs. What do? They reduce the prostaglandins.
Prostaglandin,
right? Yeah. So they will have fever-like features, high temperature. So temperature will be raised. And common bradycardia comes under less common. So common side effect is, I am talking only about common side effect. I will not touch uncommon. No need to remember also. Just we will remember common only. Temperature is from fever. Then pulse, tachycardia. Whenever we have fever, what will happen? Tachycardic. So remember tachycardia. Then BP, as you said, it is a vasodilator. There will be hypotension. And RR again, don't tell less. Say apnea.
Apnea.
The main problem.
And they like this word, apnea. That's why you have to keep alert ICU people.
Yeah, apnea. And so you will keep the baby in NICU, continuous cardiopulmonary monitoring with a set ready for intubation or with ready for ventilatory support if needed. This much you have to tell. Okay. The most common side effect, you can start with apnea. Remember all these things extra, but start with apnea. And so this baby will always be admitted in NICU and will be given respiratory support with continuous cardiopulmonary monitoring, with keeping the instruments ready for ventilatory support anytime needed. This much you have to tell in one sentence for this apnea. Then hypotension. What else I left? BP, sorry, RBS, very important. RBS.
Blood sugar.
In any critical patient, we check RBS, right?
Yes, all
As
the
a routine. It means any drug ingestion, any critical child seizure, anything, RBS is common, right? So remember here, RBS will also be, and it will be hypo. These 5 are the common side effects. That's it.
Hypotension, hypoglycemia. Remember like that.
All see, we can remember like this. Fever. When we have fever, what will happen? Tachycardia. Since it causes vasodilatation, so hypotension. But this apnea is the commonest, and you should tell in the top. So apnea and reduced RR, you can say.
This is what they want to listen first. Apnea.
Always don't go this temperature and all first. Go with apnea first. Then all others we can say. So let's put like this now again for revision, not to forget. So the first thing we'll put apnea. Then all you can put temperature increased, pulse increased, then BP decreased, and sugar decreased. Only these 5 side effects is more than enough. That's
enough.
More than enough. And this is the management you will tell. And you will shift to the baby to the tertiary cardiac center for any palliative or definitive surgery. That's it. And another, for this, the differentials for the top you will give is the right-sided heart lesions here. Okay. So the right-sided heart lesions, again, let's draw the heart to remember. Wait, I will draw. Okay. So I will draw only right side, because here we have to remember only right-sided heart lesions, the pulmonary artery. So we will start here. Pulmonary atresia, critical pulmonary stenosis, 2 things here. This is PP, then tricuspid atresia, and tetralogy of Fallot will be TT. And one more thing I forgot. And also this was transposition of great arteries.
TGA.
Yeah. And total anomalous pulmonary venous return. All these will come here. Okay. So mainly tell duct dependent right-sided lesions. Duct dependent right-sided lesions are usually cyanotic. Duct dependent left-sided lesions usually present with pallor and shock. Later, at a later stage, not at an initial stage, they can go into cyanosis when there is too much problem. Yeah. So give me your comments. Maybe if I have missed anything, please give me your comments if I have missed anything. I just studied to give the case to Dr. Yasser. Only this one I could do today. I couldn't cover the other one.
You covered most of this for the cardiology. That they said that you can, if you, as we said, 60 is the one you will go for pulmonary valvoplasty. Okay, 60 gradient. And even if sometime go with 40 to 60, if the artery pressure, if right ventricular systolic pressure is high or there is depressed function, even they go below 60 that time. But for critical pulmonary stenosis, they said without even, regardless of gradient, they go.
Yeah, so see here what he has written, he has started with 40 only. So we will tell you percutaneous, I am reading what you have sent to me. Percutaneous balloon pulmonary valvulotomy is preferred in moderate. Moderate, the gradient will start from 40 to severe greater than 60. So even we have to tell from 40, because they are considering from 40, more than 40. is moderate also. It is the
Okay.
first line treatment of typical dome-shaped valvular pulmonary stenosis, and in severe stenosis, gradient greater than 60 mm of Hg. BPV is also preferred treatment in neonates with critical pulmonary stenosis. So
Even that time, they don't see the even gradient. They said even if it is critical pulmonary stenosis, without gradient, you will do the valvoplasty.
because this critical pulmonary stenosis will present in the same way what the case we presented today.
Yes, yes, yes.
So
That's right.
urgent prostaglandin infusion and transfusion to the cardiac center. For this, maybe balloon valvuloplasty they will do.
Yes.
Okay, so now tell anything. If you have read anything about TOF, you can share your knowledge here.
TOF, I read also.
Dr. Adnan's time is finishing.
No, I have still 5 minutes, no problem. 5-10 minutes. For tetralogy of Fallot, just they may ask you in the ECG, you will find the right axis deviation and the right ventricular or with right atrial hypertrophy. In the echocardiography, definitely they are looking for the lesions and size of the pulmonary arteries as well. In the chest X-ray, there will be, which we remember, boot-shaped heart, or there may be oligamic lung, and pulmonary arteries will be small again. Okay,
Yes.
and when we are doing this surgery, all this depends upon the child. If it's present, how it's present, it will depend which time it's present. Like if it's present critical, so it depends upon the lesion. First, the second, age of the child, or the not age, sorry, weight of the child. Weight of the child, two things, and what else?
Weight of the child,
Maybe
and also the what
They
is
can
the
ask
ideal.
you this question,
can ask
management of cyanotic spells. Since you are the candidate today, tell us management of cyanotic.
cyanotic spells, like you will start airway, breathing, circulation. Then you can start to give this. You will keep the position, this squatting position, knee chest position. Knee will be at the chest of the child. That will increase the vasoconstriction, and venous return will decrease. So this will help. And morphine you can give. You can give any vasoconstriction or beta blockers in the form of propranolol. And if the child is having this acidosis, sodium bicarbonate can be given. What are the complications for the tetralogy of Fallot? There are complications like thrombus formation can be there. There can be abscess, hypercyanotic spells. There may be sometimes they may present with infective endocarditis. And what else can be there? Hypercyanotic spells and abscess, infective endocarditis.
They can also present with stroke
And
because of this thrombosis.
yeah, thrombus that I told,
Oh,
thrombus
yeah.
abscess formation.
They will have this polycythemia, right? Because of chronic.
Yeah, they in the CVC they will, polycythemia will be there. PCV will be increased. Packed cell volume ratio will be, I mean to say, hematocrit will be increased. So exertional dyspnea they may have, and the complications like failure to thrive, not gaining the weight. These all are complications that are associated with this tetralogy of Fallot.
Yeah.
And I think they have written 2 more indication to when to do the surgery. This is the weight of the child was there, and the how is critical presentation.
Weight and age.
Weight, age, how much critically child is presented.
Yeah.
Like how much critical is this one. And I forget, maybe they have written in this mark.
This
more
one.
Or you want us to read from patient info
This is
No,
the
this mark bit is more than enough.
for TOF? Okay,
Yes,
I
yes.
will see.
That
Okay.
is more than enough.
Okay, I will. I did not read. I will go and read back today so that we can finish
Yes,
this case.
I
Better
have booked.
to
I will check.
finish
Just 1 minute.
then
I
and
will check.
what? You want to tell me the page number or what?
Yeah, this one. Just 1 minute. I will open. They have given the for the treatment is corrective surgery. That is repair of VSD, and they have written this augmentation of the right ventricle outflow tract is usually carried out within the first year of life. So time depends upon severity of the right ventricular outflow tract obstruction, which I told you, the clinical severity of the lesion, this one, degree of hypoxia, this I forgetting, and the size of the
Degree of
child.
hypoxia is very important because cyanotic spells.
So if they have used this old one BT shunt, then there will be loss of which side light. If right thoracotomy scar, right side pulse will not be there. Absent pulse will be there. Okay. And if on the left thoracotomy scar, left side absent pulse will be there. But if they have used, this is classified. If they have used this modified BT shunt, then there will be no problem. Now they are using the modified.
Now they are doing modified vitation.
Now, yeah. Now they are doing the modified. So complications again, which I have told you, yeah, arrhythmias. One exertional dyspnea, cerebral thrombosis, brain abscess, infective endocarditis, arrhythmias, and paroxysmal hypercyanotic spells. So all these things.
Tell me the
So
page
this is
number in the mark, please.
Page
mark
number 185,
186.
185, 186.
Okay.
Yeah, this one is more than enough. No need of further go.
Yeah. Okay.
Okay, I think 8 o'clock now.
Okay.
Okay, tomorrow we will do.
Yeah. Tomorrow we will do, and also I think we have to try to cover because the time will run fast. At least 3 cases we have to try to cover. Let's
Yes,
see.
yes.
We
We
will
will try,
plan for
inshallah.
3 cases. If possible, we will do 3 or we will do 2. But let's
Okay.
plan at least for 3 cases so that
Okay.
we'll prepare more.
Okay, thank you. Thank you very much.
I will message you. Okay, you can.
Okay. Okay, Allah Hafiz.
Yeah, these are the 2 areas where you can get the innocent murmur.
Okay, fine. Yes, next.
Next is the venous hump we can get in the neck or in the liver. There also are innocent murmurs. And second, they cannot change with the respiration, and they are not changing with posture.
This is the important, na? Innocent
No,
will,
they
will
don't change with respiration, but they change with posture, right?
No, innocent murmur will change. Sa?
With posture, some murmurs, I think, I don't know, stills murmur. We heard in lying down position or sitting position, stills murmur.
They are aortic regurgitation murmur
Aortic
that we
regurgitation.
lean forward, and there is, I think so.
See, I will tell you,
I
I just
know
read
this
it
point.
in the morning. Aortic regurgitation, as Dr. Yasir said, when you lean forward with expiration, you can hear that better. That's called Corrigan sign. Right, Dr. Yasir?
Yes.
Yeah, I don't know about the sign, but that I know. But for the innocent murmurs, we have to know this, like how to differentiate between pathological and innocent murmur.
Innocent murmur will change with position, and it will not follow with the pathological murmur. It will change with the position. It will character will be soft, will be grade will not be more than 2. 3, 4 things they said us that day. Innocent murmur will be soft. It will change with the position, and grade will be like 2, not more than 2. 3 and 4 you get in the pathological murmur.
And also one more thing I wanted to tell you, which I forgot. For pulmonary, whenever there is pulmonary stenosis, you will always comment on the S2. Okay. S1, S2. Sometimes what happens when there is pulmonary stenosis, there can be split in S2.
Yeah, because of ASD, you mean?
No.
Sometimes there can be split in the S2.
Yes,
you mean?
Yeah. What happens normally, let me tell you. In S2, what happens is S2 is due to closure of aortic valve and pulmonary valve, right?
Mm.
Now, what happens whenever there is pulmonary stenosis, the pulmonary valve will get closed late
Mm.
because of the stenosis, the emptying from the right ventricle is delayed.
Yes, you're right.
So it
Okay.
will get late. So you may have split S2, means aortic valve will close. Then after some time,
After some
pulmonary valve
time,
will,
pulmonary stenosis,
yeah, if
pulmonary
there
valve
is
will
something
close.
like that, you should also ask for S2. You should ask for S2.
I got
Because
your
I'm
point.
hearing-
You mean the aortic valve will close early, then after some time the pulmonary valve will close because
Yeah,
of this.
yeah. So whenever you have pulmonary stenosis or aortic stenosis, you will ask for the S2. Is it
Okay,
normal,
okay.
or if there is any split, or if it is soft, something like
It
this.
is loud or soft, or there is any
Character of
split.
S2. Yes, yes, very important one.
Okay, I got it.
Because this was told in the exam to some candidate that you did not comment on the S2.
Okay, I got your point.
So comment on the S2 in stenosis murmurs.
Dr. Noor, regarding this functional murmur or this innocent murmur, you are right that they are asymptomatic, systolic, never diastolic, short, not loud, less than 3 out of 6,
Yes.
head
Yes.
over limited area of the precordium with the normally split second heart sound, changing with posture, Sorry,
Yeah, change.
not
Yes,
associated with heaves or thrills with normal investigations such as ECG, chest X-ray, and echo. Example is venous hum. It's a blowing continuous murmur heard just below the clavicle, and it varies with change in position of the neck and respiration. Second one is pulmonary flow murmur. Is a soft ejection systolic murmur in the pulmonary area. And then is vibratory murmur, still murmur, is short buzzing murmur heard over the left lower sternal edge or apex, which change with posture and usually disappear by puberty.
This is which page of Mark you are reading?
Yeah, I am survival guide. I'm reading survival guide.
Page number
34.
Okay, good. I will go back and check because I was thinking I should know about innocent murmurs. Okay, Dr. Rehana, it's not given anywhere separately innocent murmurs in Mark.
I did not see yet because I did not complete CVS there. If I check, I will give you the page number.
Okay.
I did not complete the whole CVS.
Okay.
It will be for sure there, I think. I will check.
It has to be there. No problem. Okay. So I think today we will end the meeting. And tomorrow we will plan.
What is your plan? This one 8 months, this one 8 months, and that one 7 months.
Yeah. So I'll just read so that it's like as if we finish this case, we will move to the next case. Then I will tell you the extra cases what to do. Let's finish the Mark first. So 8 months old girl, she appears small for her age. Although I would like to plot her on the centile chart, she is tachypneic at rest. So RR is there, means slight tachypnea. She is centrally cyanosed. She has no dysmorphic features. She is clubbed and has peripheral cyanosis. Same like what you did today. Central cyanosis.
Yes. It's almost the same because this is also
Clubbing.
post-surgical.
No dysmorphic features. She has right-sided thoracotomy scar, but in this case, you had shown left side.
Left thoracotomy.
Auscultation, she has normal first heart sound and single second heart sound. See, always you have to comment on the heart sounds when you...
Second heart sound, yes.
Whenever you are telling on auscultation, what is your finding? Comment on the heart sounds, then comment on the murmur. Directly don't jump on the murmur. Okay? On auscultation, she has normal first heart sound and a single second heart sound. That means there is no split. Single second heart sound means there is no split. Has a normal first heart sound and a single second heart sound. She has a continuous murmur over the right side of the chest. There is continuous murmur over right side of the chest. Let's see where he has written. At the end of this examination, you should suggest palpation of the abdomen for liver and taking blood pressure. This set of clinical signs would fit with a child who has complex cyanotic congenital heart lesion and has had shunt procedure. So we'll say palliative procedure, as you said, instead of shunt procedure. And here you see there is no median sternotomy scar. That means only palliative procedure is done for.
That is only the palliative done here.
Yes, this is the clue here for you. So the possible diagnosis include pulmonary atresia without VSD. So that means pulmonary atresia.
Yeah,
Again,
because if it is with VSD, there will be mixing. So without VSD.
yeah,
That's why
there is
cyanosis.
mixing, and they need not have to go for this shunting. So pulmonary atresia without VSD. Again, it's a right heart lesion, what we read. And double outlet right ventricle, univentricular heart with pulmonary atresia. See, again, pulmonary atresia came here, but with single ventricle and double outlet right ventricle. So because here he is not telling other things like tricuspid atresia and critical pulmonary stenosis, because this can be corrected by cardiac catheterization or what?
No, these are also complex. Double outlet right ventricle needs stage
No,
surgeries.
not double outlet.
No. Whenever there is valve involvement, then we can go with the balloon valvoplasty.
Yeah,
With
stage
atresia,
one.
we have to do surgery, corrective surgery that we call valvotomy or valvectomy. Corrective surgery we have to valvoplasty we have to do, and that is through the sternotomist car.
For what? Atresias.
Atresia.
For
No,
atresia.
they have done here only the palliative, Dr. Yasir, in this case.
Nana, we're discussing differential.
Oh, okay.
No, I was telling, suppose why they did not put here, my question is why they did not put here critical pulmonary stenosis and tricuspid atresia or transposition of great arteries as the differential. This is my question. So for critical pulmonary stenosis, I am
Because for
thinking,
TGA, you are not doing any palliative surgeries. TGA, you are doing direct arterial switch.
direct
No,
artery.
Fontan, we are doing the font with this one balloon.
Balloon
Yeah.
atrial septostomy, if they don't have VSD. If they don't have VSD. But if they have VSD mixing, good mixing, or they have good PDA for mixing, then they will go direct arterial switch, because as early as you do the switch, that good is the prognosis.
Okay.
As early as.
Okay, here they are not telling pulmonary stenosis. Maybe that can be corrected by cardiac catheterization.
Cardiac catheterization, yes.
That's
Cardiac
what they are
you
not-
don't need for pulmonary stenosis, you don't need palliative surgery.
We don't need palliative surgery, as well as don't need this central sternotomy also.
Yes, you will do bilateral. You will do bilateral thoracotomy.
So we have to give these differentials. For your case also, we can give this differential.
Yes, because our case was both lesions, both scars there, lateral also and median sternotomy also.
So for that, we will do this pulmonary atresia without ventricular septal defect, double outlet ventricle and univentricular heart with, okay, you would be
cyanotic. The one will be cyanotic, the node of the node. Even though TGA is cyanotic, but we don't do palliative surgery there. We do only balloon atrial septostomy for mixing the blood until he goes for corrective surgery.
But you will not do this BT shunt. This is for BT.
Yeah, no. Arterial switch, we don't do any shunt or anything. We do just balloon atrial septostomy, as Dr. Yasir said, for the mixing, and then it will go as soon as he goes for switch. That is better for the baby. Like in 4 days, 5 days. In our center, they do 2 days, 3 days arterial switch. 4 days, 5 days of the age they do switch, and khalas, that's the end of the story of their surgeries.
You would not be expected to come up with the diagnosis, but carefully elicit clinical signs will allow a best guess. In this case, with the shunt and the single second heart sound, see, in this case, there is a shunt, we made a shunt, and the single second heart sound, a diagnosis of pulmonary atresia would be first best guess. Fallets is less likely because there is no systolic murmur. Here, because it depends on the finding. Here, there is no ejection systolic murmur. The murmur is continuous murmur. So
that is BT shunt murmur, continuous murmur.
Yeah, Fallets is less likely because there is no systolic murmur of pulmonary stenosis. And in pulmonary stenosis, there should be 2 components of second sound. See, you should comment on second sound. This was told in the exam to one candidate. Everything
Yeah, I
you did,
forgot.
you did not comment on the second sound.
Yeah, I forgot this one. Yes,
You also
yes, you are
did,
right.
you also did not tell, he also did not tell, I guess. Rohit.
Because I did not do in the exam also. In exam also I did not say that, so I forgot here also.
Yeah, you have to comment, because in pulmonary stenosis, you see what he has written very clearly here. In pulmonary stenosis, there should be two components of second sound. Why here phthalates did is not in this case? Leave about our case. In this case, why phthalates is not put on the top is because of
Because
two
this
reasons.
murmur is different.
Yeah,
Mm.
she has a continuous murmur over right side of the chest, and also there is single, very clearly he has written single second heart sound, but in the pulmonary stenosis there will be split of the second heart
Second
sound.
heart sound.
Okay, I think better we will do first the mark cases, and then we can go for the exam cases. Okay,
Okay.
so
Okay.
tomorrow,
And they will be similar to. So by the way, they will be similar to these cases.
yeah, this will come, this can come in video also. So tomorrow Dr. Yasser should prepare one case, and Rohel should prepare, and we will be the candidates tomorrow. Okay, so Dr. Yasser, in this there are 6 cases in mark. Choose any one case and message me. Okay,
Okay. Okay, I will do.
no, let the role player message, then we will decide which one.
Okay. Then they will decide. Okay. Okay.
Okay, I will message you. Okay, is
Okay.
that okay, or you want me to give the case, Dr. Yasser?
No, no, I will see, I will, because I just started. I was, today I am completing the, what we call